Perfecto. Soy Stephen Wallace Sánchez, aquí en República de Dominica. Gracias para mi amigo Alfonso Gómez y el presidente Dr. de León también. Pero mi español es muy malo, so más inglés aquí. So. Today I have three lectures, mostly focusing on bone defects and how we manage them. So the first one starts out a little more academic, and then it becomes very case-focused with muchas fotos. Es muy bien. So, but I am in private practice in Portland, Oregon. In the Pacific Northwest. It's very green, a lot of trees and volcanoes that do not erupt. But you know, I did two different fellowships. One in acute orthopedic trauma. Did a lot of acute internal hardware, plates, screws, nails, and then I did a second deformity fellowship or reconstruction fellowship in Manhattan across the country, dealing mainly with kind of chronic deformity, like length discrepancy, things like that. My practice today is a lot of in between, dealing with infected pilons, you know, subacute bone defects, and more kind of subacute issues. But I use a lot of frames and lengthening nails. So today, this first lecture is focused on kind of managing how we manage bone defects in my practice in the United States. So there are some classifications. It's kind of a riff off of the AO classification on how to categorize bone defects. This is done by Tetsworth, who lives in Australia. It's basically a continuation of the AO classification, helpful for research papers and just trying to get a sense of, oh, how big is a big defect? But kind of general methods of fixing bone defects, I kind of categorize in kind of two different columns. One is with distraction osteogenesis or growing new bone, and one is non-distraction osteogenesis. And so on the left column is how we were kind of traditionally trained, most of us, you know, mostly bone grafting, whether that's, you know, Mascalais or acute bone grafting, or struck grafting. That's a fibular vascularized allograft, autograft, or now we're doing more kind of 3D metal cages. What I primarily focus on is more biologic distraction osteogenesis, and we'll kind of focus on this right column of the frame, plate-assisted transport, and then transport nail. And then there's another concept I call backdoor transport, which is kind of a shortening and then lengthening later, which I'm sure all of you guys have done before. So just to review Mascalais, it's typically a two-stage procedure. The first is debridement. You get rid of all the bad bone, and you put a cement spacer with antibiotics to create this pseudomembrane around. And then stage two, typically 6 to 8 weeks later, you go back in and bone graft, typically depending on the size of cancellous allograft, autograft, and sometimes antibiotics as well. Struck grafting, just to kind of go through all the options, is traditionally cortical grafts taken from a cadaver bone. Better is likely a vascular graft if you have access to that. It would be like a free fibula vascularized graft. And then now people are 3D printing titanium cages, which graft can go inside. So there's some new up-and-coming strategies to do that, and I think there's some advantages to that, but in the correct patient. So, you know, how do these bone defects typically occur? Most of the time it's high-energy open fractures. A lot of time it's a result of infection osteomyelitis, ballistic trauma, failed fixation, or in the oncology world, tumor or non-union resection. So going over the three kind of forms of distraction osteogenesis, a lot of different ways you can do it. One was at the frame. And I'll show you some modern techniques of how we do that. One is called plate-assisted bone segment transport. It's where you have a plate that's stabilizing the length, and then you're transporting a segment with a motorized nail. And then there are these specialized nails that kind of all-in-one, all-internal, able to transport a segment within a fixed construct. And those have quite simplified some of these cases, but are not always available, including my practice. I don't have access to a transport nail. So just to get people familiar with some of the terms of transport, we talk about how many segments we transport, what direction, how we do it, and then some specific techniques on how we do it safely and effectively. So here, when we talk about a bifocal transport, it doesn't mean there's two segments moving. It means there's one segment moving where you have an area of distraction, making new bone, and another area where you're filling in the gap. This is your quote-unquote non-union, and you're filling in that gap. So to go a little more advanced, trifocal doesn't mean three segments. It means three areas of activity. So you have distraction here, and then filling in this gap here. And then you can have what we call tandem, so these two are going the same direction, versus converging, which these are meeting in the middle, versus diverging. There's certain situations where you have a vascularized segment in the middle, and you split it to fill in the top and bottom. So requirements for good regenerate, you want to preserve the periosteum. Old school thought, back from Elizarov, was you had to preserve the endosteum, but we're using a lot of motorized nails these days, which are all intramedullary, so some people are questioning that. You need a stable mechanical environment. Some people think that fractures like to heal in compression and compression only, but distraction reduces the shear, which improves your mechanical environment for healing of that distraction. And then obviously you need a healthy soft tissue envelope. And this comes into play with your plastic surgeon as far as, my first priority in these big reconstructions is I need a closed, non-infected limb. And sometimes that can be a challenge as that first step before you reconstruct the limb. So here, techniques for making an osteotomy. Traditionally, I was taught with the de Bastiani technique, multiple drill holes completed with an osteotome. There's some other ones that I'm not trained in, but I think are useful. Would be the Gigli saw, the Gigli saw, and in some cases an intramedullary saw. Can be very percutaneous. This is a study that came out about 1.5 years ago, basically combining bone transport with masquelade. They found out that if you had masquelade, stage 1, put a spacer in and had this pseudomembrane, that rates of union at the docking site were improved if you had a masquelade done before. So they had faster docking site non-union rates, lower non-union rates, lower infection rates, lower additional surgeries, and no difference in how long people were in the external fixator. So I thought that was helpful. So going a little deeper into some of these techniques. So this is traditionally kind of frame transport. Here you see this segment is connected with Chance pins that transport the segment directly down. Taking that up a level, Dr. Quinnen in Florida had theorized and came up with this technique to do balanced cable transport, where a cable is routed through the segment, and that drags like a horse and carriage down and around to pull this segment down. So here's your osteotomy up here, bringing the segment down to fill this defect. This is just a temporary spacer. So, and I'll show you how I've kind of advanced on that topic. The problem with these traditional techniques are very related to an external fixator, and I'll show you some tricks later. The second option is this plate-assisted bone segment transport, where now your length stable is through this plate across, and you're transporting with a motorized nail. So this is termed Pabst, which is a common, very cheap beer in the United States. And then you have your transport nails, which have a slot in them and motorized to transport a segment straight, but maintaining length stable there. So here is a schematic of kind of next stage. Here we're automating our transport frames, and this is what's gotten a lot of attention recently. And so now, instead of just doing one segment, we can start doing 2 segments. And there's a whole nother lecture on how we rig these up to allow this one to move twice as fast as this one, so you get relative same distance and then your distraction rates. Very, very simple, very easy mechanical ways to do this, but intimidating to look at first glance. And now converging, here's the model for that, where we're meeting in the middle. These are all filmed in my kitchen, by the way. That's why I'm still a bachelor. And now we're doing it trifocal with internal lengthening nails. And this would be more of a PAPS type case. A couple different ways to do that. And here playing with the idea of not cables, but using sutures, which are just as strong. So that's segmental bone loss. Perfect. I think we'll go straight into my second lecture, and then we'll have a guest speaker for in between my second and third. So we can load up the circular external fixator. So this lecture is basically showcasing a lot of applications for circular external fixation, not just cable transport, which has been my thing for the past couple of years, but some other applications. And so, let's see. It's not letting me advance yet. There we go. So external fixators come in a lot of different varieties, right? So here you're used to your trauma application here, just a uniplanar external fixator. Here we get a little more complicated where we have these linear struts. It's just a holding frame. Then we have a hexapod, and then we have an automatic hexapod. So various degrees of complexity, but different uses, all very powerful. And so here, traditionally people, this stuff was not taught in my residency. And like I said, I was taught fractures like to heal with compression and compression only. And so the idea of an external fixator, which, has, relative stability, was just kind of hearsay. But, you'd think it would not be within the AO principles, but if you take a closer look, the Elizaravian principles are the same as AO principles. And so, based in 1960s restoration of anatomy, you can control the anatomy with the frame, stable fracture fixation. These frames can be extremely stable to the point where, most of my frames are fully weight bearing. Preservation of blood supply. I mean, this is all minimally invasive, right? And so you're keeping the local blood supply and anatomy around the fracture or non-union site. And then early mobilization. Like I said, these frames can be built strong enough where they allow full weight bearing. So to me, this is very AO, and the AO over the last couple of years has finally caught on with more external fixation kind of courses and integrated into the resident curriculum. So, but all sorts of different applications, whether from traveling traction to holding frames, a frame to compress, and your frame will vary depending on what function you need it to do and kind of the local anatomy you're working with. So if you need to pull through a stiff non-union, you're going to have a lot more power and fixation than just a simple holding frame for an acute fracture. So here's a case, very simple external fixator, but used a ring for some specific reasons. So there's a 36-year-old male motorcycle accident, He had this open wound which was temporized, and then his skin just over a week's time is necrotic and died. But this is how he showed up to my clinic with a simple kind of trauma X fix. For me, in my practice, my plastic surgery support is not very robust, and so I know this frame in my practice is going to be on for a long time. And so this is his initial, this is his clinic films in my clinic. And then, so I converted him to kind of this simple frame. You know, the bar, the transcalcaneal pins are going to erode through the calcaneus fairly quickly. So I often convert to a thin wire frame if they're going to be prolonged. But this is a nice, even a ringed external fixator allows very good access to this wound. And so if there's going to be an external fixator on for longer than 3-4 weeks, I'm converting them to a thin wire frame, at least in the distal portion. You can still fix to half pins directly through carbon fiber rods if you need, but this guy needed a little extra stability and I wanted to control if I needed to add length. And so I put these quote unquote trauma struts on. So that's just one example of kind of a simple ringed external fixator. Here's another case, acute trauma, pedestrian versus auto. He developed compartment syndrome, was seen by one of my trauma partners who's very good, but had severe blistering. You can see his fasciotomy. He's going to be swollen, and you know, with his injury, which is simple intra-articular, but still intra-articular, I think this was a good case to do a frame while things kind of calm down. I'm early to convert to internal fixation, but even a nail would be a little aggressive in this for me. And so we put him in a simple, we did fragment-specific fixation of his articular surface there, just percutaneous through small incisions, and then we applied this hexapod frame. And what this allows us to do is hold things in place and actually manipulate. We can reduce that fracture after surgery to get good healing and good opposition while his soft tissue improves. Could we have left this on for 3-4 months and potentially let the bone heal? Yes, but after 6 weeks, we converted into internal fixation. And so we put a lag screw across that oblique fracture, and then we were able to do delayed primary closure, so he did not need any skin flaps or skin grafts either. And so here he is 6 months from his initial injury, and he's walking, he's closed, and he's healed. So no pain. So, all right, let's keep upgrading. So in the deformity world, here was referred by my total joint colleague who said I can't do a total knee in this patient despite his arthritis. 75-year-old had a fracture when he was 12, treated in a cast, but has progressive knee pain and instability. So for this case, he had extensive recurvatum deformity with translation in the setting of arthritis. For us, it's hard to do an acute total knee, and so the goal was to get him into the range of where a total knee would be appropriate. So in a 75-year-old, doing distraction osteogenesis is a little spicy, but we did it anyway. So here we are, we apply his frame, we fix his syndesmosis, make our osteotomy right at the apex, and granted we went very slow, but we were able to correct him to a point where he was growing new bone. He had better anatomy to fit a total knee. And so, but the name of this game is slow to create that new bone. So after the frame was off, tenuous bone growth, but that would continue to consolidate. And so we sent him back to his arthroplasty surgeon who did a stemmed but relatively straightforward total knee arthroplasty. So no infection, no augments, a simple stem to protect things, but he's back walking and now needs a total knee on his contralateral side. All right, here we go. This is getting even more advanced. So 38-year-old infected pilon. This is how he showed up to my clinic. Osteomyelitis here. Had prior infection, hardware removal. Prior surgeon cleaned him out, but he was still draining. Had an open wound too. And so we attempted a masque-a-lay. It's like, all right, we'll try. It's supposed to work. Distal tibias are hard, but he was young, healthy otherwise. Okay soft tissue envelope, but we put a spacer in for 6 weeks, then went back in, did some iliac crest bone graft and allograft. But this frame, like I said, very powerful. He's weight bearers tolerated throughout this process. Walking with a cane because there's some height differences. But overall, you know, pain very reasonable. But anyway, he ate through his graft, and so failed, and so we had to do a bigger resection, and then this is where we started to transport. So like I showed you before, this is a trifocal. We'd set this up as a trifocal. Advantage of that, you can close that gap twice as fast. And so here is a very traditional technique as described by Quinnen. This segment here is going to move at 1 times down. It goes down and out the skin here. This one here goes down and around, and it's a series of pulleys that makes all set up to this motorized unit. So this ring is going to move up. It's going to tension the cables around and pull down to fill in the gap. So we automate it. So that's what that looks like. Not too complex. And here's that describing. So this segment goes down, 1x the speed. So every millimeter this moves up, this is going to move down a millimeter. And this segment here is going to move down 2 millimeters. And so here he is in transition. Here he is docked. Auto struts are designed to stall out. And so you know you're getting good compression. And I'll leave him compressed for a little bit. I was a little nervous just because of his docking site, and this is one of the earlier cases I did. So I put some tension wires over the remaining one after I nailed. Stabilized the intercalary segment here through a custom screw hole, and here just through the distal interlock. But here he is walking. Probably doesn't need the crutches. And here he is later, consolidating and consolidated, and he's healed. Perfect. I think that's it for that lecture. Perfect timing. Happy to answer any questions at the end of this session or upstairs. So.
At the end.